Okay, great. So good afternoon to everybody. My name is Sheila. I'm a developmental nurse and the cord blood bank nurse of Israel. We are hosting a new doctor today, Dr. Felician. And
Hello.
hi, how are you? Why don't you tell us a little bit about yourself?
Thank you for this invite. I was starting in stem cells field back in '95 in New York under Professor Nicolae Ciobanu. And at that point, the only known use was with the hematopoietic stem cells from bone marrow. And it was done for bone marrow transplant for various oncological and hematological disease. And only very recently, with the advent of mesenchymal stem cells, I got, sorry, um, I got involved into regenerative therapies. And my first patient treated this way was 15-year-old in a neurovegetative state, and there was some progress. But this led back in 2019 to the first patient with ASD, whose parents was very keen into administering this type of treatment, a new treatment at the time. I was very reluctant to administer it because I didn't know much about the use of stem cells in autistic spectrum disease. And I postponed the administration for a few months, waiting for other treatments to take effect. But when I finally agreed to it, and we did it back in January 2019, that was the first patient in our series. I was shocked to see after 1 month the kid making big, huge progress in interaction, in verbalization. And that was the time I decided to go on and do this treatment for other kids. Not all the kids who receive this autologous cord blood make huge improvements. The later years, after 8 or 9 years of age, the administration of this autologous cord blood is less efficacious. And in our experience, the percentage of the kids who can benefit is decreasing. In the age interval 3 to 7 years, the percentage of kids making progress was around 2 out of 3, around 66, 70%. And some of these kids have huge improvements. And over 8, 9 years and over 35 kilos of weight, the progress was less in terms of percentage. Just 1 in 5 kids, around 20%, showed improvement, and not as much as smaller kids. So this adds to the uncertainty of the outcome of the treatment. On the other hand, autologous cord blood is very safe, its own blood, and this was our own, first criteria. First, do no harm. So the risks are very little, if any. And the second thing is we have not seen any regress in patients with ASD, meaning that there is no loss in acquisitions of the kid. And even though in some kids the progress is small, we have not seen trouble in these kids. This is the first thing that most parents would need to know. So smaller age is advantageous, and not all kids benefit from it, but some kids have impressive results.
Okay. You work in a public hospital, right? It's not a private institution.
We do all this in a research setting, and this was much easier to have it done in a network of private hospitals. It's a Medicover hospital, which is also present in Poland and has one hospital in Bucharest. And the first patient was actually administered in Angiomedica, and this is also a private hospital with a specialty on cardiovascular disease. But they are not doing pediatric interventions anymore, just adult. So I had to reroute to Medicover. So it's only private hospital. The public institutions, public hospitals in Romania are not very keen to work with the cord blood. There's a lot of reluctance because in the traditional therapeutic use of stem cells, bone marrow stem cells and peripheral blood stem cells are linked to a transplant with less problems. And they have been favored since 2012 for the past decade.
Yes,
And
we see it everywhere. We see it all over the world. So you have a research center in a private hospital, and you treat the children there. How many children can you treat in one week?
we want only one administration per week, so I can personally handle all the aspects of it, and I can make sure there's no mistakes. We had two patients once in this summer because of overlapping, and it was not a stress, but sustainably, it's about one patient per week.
Okay, can you explain about the procedure itself? What happens from the moment a child comes in until the moment he leaves the clinic?
The administration itself, it's pretty unspectacular, and it takes place during same day hospital admission. So the parents and the kid arrives around 8:39 a.m. at the Medicover Hospital in Bucharest. They get admitted to regular admission, on top of which there is the protocol for research for this clinical study. And they get sent to the pediatric ward on the second floor, and they are under the care of the chief of the pediatrics section, Dr. Aluka Bogdan. And if on call there's another doctor, they also evaluate the kid. At any time, the parent will be with the kid all the time. There's no separation. And there's a spacious room where the parent also has a sofa to rest if it is the case. The intensive care specialist comes into play next because Dr. Radu Dumitrescu, who's the intensive care specialist and also the medical director, evaluates the kid and administers the pre-medication, which is making sure that the kid will not have an allergic reaction. And this
What
is
do you
standard.
give? What drugs do you give for pre-medication?
Cortisol-based drug and an antihistaminic. This is
Okay, same like we do here.
and Duke. This is after the Duke protocol.
Yeah, we also give some paracetamol.
If the kid is very agitated, and maybe 1 in 5 kids, they don't like needles and they're not used to holding the catheter, the venous catheter in place, and some of the kids receive midazolam and they briefly go for sleep. But the next step will be during all this time from 9 until 11, I'm decryogenating the cord blood, treating it with dextran and albumin, and around noon, I bring it for infusion. So after the pre-medication, the next step will be infusion of the cord blood itself, which
I want to ask you about this because I work with a lot of doctors from a lot of places in the world, and I have to say it's the first time I see cord blood being given anything to make the cells do better. So can you explain our viewers a little bit about why you inject the cells with these substances, or infuse the cells actually with these substances?
yes, there are many studies which try to show what is the best environment for the stem cells to revive, to be active again after they get thawed, after they get bring to room temperature and 37 degrees. And I remember back in 95, 96, when I was first seeing the reinfusions in oncological patients, literally the bag with the DMSO, and these were huge bags of 250 mLs. For the kids, we give at most 60 milliliters. So these huge bags were brought to room temperature at the patient bedside and reinfused. So no preparation whatsoever. And the results were okay. These patients were recovering the white cell population and later the platelets. So this was the early days and it worked. But the Rubinstein protocol was showing that the external recovery is done if we treat this cryogenated blood with dextrane 40 and albumin in order to bring the osmotic pressure of the extracellular environment where the stem cells is decryogenated closer to physiological values. And indeed, for each of these thawed units, we did viability testing also on flow cytometry with the 7-actinomycin D. And this show viability of population, CD34-45. We also do extra the CD271 positive and the CD133. And besides variation between different grafts, individual variations, we had mostly excellent recoveries, excellent viabilities exceeding 90%. And we've even had one of 99%, which was phenomenal. We had a couple out of 35 in the 80% range, all of which is very acceptable.
I wonder if you can revive units of cord blood that's been stored over 25 years old using this method, because
I
I
don't
think
have
that
any doubt.
you don't have any doubt. Well,
Yes.
if it's possible to transfer this information in writing, because I
Yes.
do have units in my public cord blood bank who are at this age, and we are trying to figure out how long can you store cord blood and have it still in good enough condition to treat. Because as you know, there's a big shortage of cord blood around the world. People are not well enough aware to need to store it. And some of the units are very, very small. And we're looking to find a way to improve this situation. And if that can help us turning 30-year-old cord blood units to something viable, then there's a reason to continue keeping them.
Surely there's a reason for keeping them. Very recently, I read about a 30-year-old embryo getting implanted with ensuring pregnancy. So
Yes, but embryos aren't cord blood. They're whole beings, while cord blood are singular cells. There's a big difference. And also, out of every 30-year-old embryo that's managing to develop into a human, we have about 1,000 dozen. So it's an issue, because here, when we're treating humans, we need to have the unit ready when it needs to be ready. So I think that maybe it's a smart idea to try and see what we can do for those older units. And I would really appreciate if you will transfer the information, or maybe even I'll make the connection between you and our cord blood bank lab to see what we can do to help the situation. Because honestly, every unit is very precious to us.
we can test one unit which may be contaminated with hepatitis B, or which can have little use. We can test for decryogenation, but the worst case scenario is to have patient who's conditioned for transplant, which means receive chemotherapy, and the white cell is very low and has to receive the unit, and there's a problem. So the viability is very critical for the transplant patients. For the ASD patients, this is not a very big issue because some of the red cells which get infused in these units, they get hemolyzed. They get destroyed anyway. And in some kids, the first urine it's pink or it's
Yeah,
colored
we
because
know it's a known phenomenon. We see children with some crystals from the white blood cells, so we know. The side effects for stem cells in cord blood are very well known. The odor issue, uh, yeah, the odor issue is an issue. The crystals that come about 4 hours after the change of urine, we know all the side effects. My main issue right now is really with those old cord blood bank units. I think that would be wonderful if we can fix a solution for them.
we
Not
should test
only
it.
for for autistic kids. We're planning on doing a diabetic patient study. So
We can definitely test the decryogenation of such older units. And one thing that we did extra, because with a patient in non-critical state, meaning that we're not doing chemotherapy first, we can do a little more than the transplanted patients. So I have observed that different fractions after centrifugation, they have different composition and viability. So we can select better the viable cells. And in the worst case scenario, we can work even with the viability of under 70% and select if it is a good, if it is a rich collection of over 400, 500 million cells, we can select, the 60, 70% minimum 200 million cells, which is still a very good dose for a kid with ASD, and use it. So we have techniques.
you think that the amount of cells per kilo is less significant than other doctors describe? Because when
Uh,
we discuss it, we say at least 20 to 50 million cells a kilo. That's the protocols I know. But if you say 200 million cell unit, then for some
it's
of the
10 million.
clinics, it's
Yeah.
only like a 4 or 5 kilo child. This is nearly a newborn.
Yes, the 50 million per kilo dose, it's especially useful for transplantation, and because it's these cells are seen as less mature than bone marrow cells. In order to replenish bone marrow and start making again the cells, so this number is more critical for transplant situations. But for example, in the study from Duke University in 2017, they used a dose between 2 to 10 million per kilo. So this was exactly their dose. We
Cord blood.
cord blood, yes. Uh,
But they now use 25 million per kilo.
I was able to infuse more than 100 million because we do not recryogenate. So we thaw the whole unit and administer it. And we don't have the possibility of doing it twice because the viability decreases. This is the worst thing that you can do for a graft, to thaw it and to
Freeze it
cryogenate
again.
again. This decreases the viability the most, not the time in liquid nitrogen storage. It's the processing of it. And
Yes, I agree. Question about amounts. So let's say I have a child, he's 5 years old. Sometimes they weigh something like maybe 17, 18, 19 kilo. How much is the minimum amount of cells per unit that you are willing to transplant?
If I go to Duke University recommendation, that would be around 2 million per kilo. The least I have done so far was around 6 million per kilo, but this is strictly on practical reasons.
You're still talking cord blood.
Yes, cord blood TNCs, total nucleated cells.
Okay.
Not CD45 positive or CD34.
Yeah. Okay.
Total nucleated cells. And from a practical approach, I had a 5-year-old of 45 kilos, and he had more than 600 million TNCs, and you don't expect first time I spoke to the mother, I thought it was a mistake, the 45 kilo weight, body weight. What I'm getting at, we have not turned down so far any kind of collection, because up to 30 kilos, that will mean by Duke standards 60 million TNCs, and I have yet to see a graft of lower than 150 million. So we have not gone into the low range.
Okay.
What I'm saying, we have not established a low limit of dose in ASD. What I think, though, is more important is the percentage of CD34 versus mesenchymal cells. I think this is more important in the outcome for the child's progress.
Because we don't check for mesenchymal stem cells. We check for CD34. That's routine checkup here. We check for total nuclear cells as well. And when you receive the unit, you check how many MSCs are inside?
No, unfortunately, I can only do this after I thaw it and after I infuse it. So it's just for getting extra information. It's not a criteria for accepting or rejecting the administration. This is still something that we analyze, and we're trying to see a correlation between the composition, the percentage, the relative percentage of CD34 and mesenchymal CD271, and try to see correlation in the results. But this is not a criteria for rejection. Actually, yes, we are trying to be as accommodating as possible, because it is more useful to have more data and then come up with the selection criteria, which means accept the patient, and then even if it's out of range, and then because there are many things we don't know, and then and in some cases we still have pleasant surprises. So rather than saying you won't benefit from it for sure, but we don't know for sure, we have too many question marks. So I rather say, okay, let's do it, because we know it's no risk, and see how much it helps, and maybe we get useful information from that for other kids, rather than say, no, I'm not doing it. And as I said, this is also based on what Duke is doing with the 2 million TNC per kilo that they accepted for infusion. But as I said, we had never had less than 5 million per kilo. And so far, we have not turned down any autologous for ASD. So this is not a concern.
Can you tell us a little bit about what you check in your research program?
We're trying to see markers based on which we can predict the usefulness of the treatment, because these are not very cheap treatments, and they're not very widely available, and this unpredictable outcome, it's telling us that there are kids who have different particularities, and combined with the particularities of the graft, of the cord blood itself, because there are differences, this makes a complex environment which you're trying to find out more about and be able to say, yes, it's 90% chance that the kid will benefit, or no, do something else. And so far, our best indication was given by the levels of NSE, neuron-specific enolase, which is high, it's above normal, and indicates neuronal destruction. And when this is also present with the inflammation, then we can say the immune system is mostly the culprit for the developmental disorder, and giving the cord blood as a good chance of modulating the immune system and improving the disease. However, in the case of NSE, which is normal, and we have encountered that in one patient, then it's better to do a genetic testing, the WES or WGS, and see if there's one or more problems which puts the cause more in the neuron side, not on the immune system side. And then mesenchymal stem cell treatment is more probably to work, because mesenchymal can be the source for new neurons, and especially the allogeneic ones can bring improvement. So this is something.
I have to say, I see this quite often with children that are going for mesenchymal stem cells. And we see that even children with some genetic problems do benefit from it. And since most of our parents here don't have cord blood. In my case, I had both, and I could see the difference. Unfortunately, we're not able to say who's doing better. If the cord blood is doing better or MSC do better. But I did see some children with MSC and genetic problems that did very well. So I'm very happy to say that's also an option. So other than this test, what other things? So this child is coming into your clinic. The first thing that they do is doctor's checkup, and then you draw blood for these tests.
We try to draw blood before coming here and before the hospital. So we have the first set before the hospital, maybe 2 days before, or it can be done the clinic to which the child is affiliated. And with this first set of blood tests, we do HLA typing to cross-match with the cord blood and see to confirm that it is the own unit autologous. So we have no question mark for the future. And also there's a set of blood tests which includes the inflammation markers, such as tumor necrosis factor alpha and ferritin or alpha-2 globulin on serum protein electrophoresis, C-reactive protein. In some cases, we do the interleukin-1 beta and interleukin-6. We also do ferritin, and it was elevated a lot in patient with thalassemia. Thalassemia, which is followed by accumulation of iron in the CNS including, and that's a big metabolic disturber for neuronal function.
So you think, by the way, that thalassemia, major or minor, can be affected positively by cord blood?
There's clearly an indication for treatment for sickle cell anemia. For
sickle cell anemia, I know, but thalassemia, this is the first time I'm hearing about it, and we have a lot of genetic thalassemia in Israel.
I don't think that hematologist will put a child with minor thalassemia to risk do the transplantation, but in our study, there was this kid who had this ASD and also a thalassemia minor and elevated ferritin levels, which is also
Yeah.
linked to inflammation. And we have seen the ferritin go down after the cord blood treatment.
Really?
But it is not.
Not self-donated cord blood for minor thalassemia with no chemotherapy.
I don't know. I don't know what to say about this. It's probably an advantage. It will induce a chimerism in the uh, child, and it is possible to bring an advantage by having some red cells with no problems. But this is a different field, and I'm not getting into it.
Oh, oh, don't worry, I will.
Okay.
I will find the hematologist who will. Hmm.
Okay. Uh, that chemotherapy involves some risk that we're not willing to take, and
Obviously.
uh, we have to balance the risk and the benefit. For ASD, there's no doubt, and the autologous is no doubt, but for thalassemia minor, there's big question mark, and
Yeah, I mean for thalassemia major, it's a different
yes.
situation, but for minor, yeah, I understand what you're saying. Okay, so we came to the clinic, we had a doctor's checkup, we either drew blood 2 days before or we didn't, and you will before, and then what happens?
Um, for the clinic, we just talked to the patient and the kid and we're trying to do some psychometric evaluation and review the and test the analysis that the kid has so far. And we prepare the parents and the kid for the administration itself, which takes place in a couple of days' time. And that will be the main event. In our study, though, another thing that we're doing is administer supplements, and these supplements are focused on lowering inflammation, lowering anxiety, and they uh, in just one child, uh, the supplements had better results than the cord blood itself. And this also raised the question of whether the child had genetic problem or immune problem.
Metabolitic condition, yeah.
Yes,
I
yes.
have to say, I experience quite a lot of children who has a mixed condition. So some
Yes.
of it is a metabolical condition, and some of it is just a mixed condition with the ASD that's also causing some metabolic conditions. So it's something
Uh,
very common.
some kids show improvement on supplements, and the first step before doing the blood test for inflammation, we're administering some plant-based sedatives, let's put it that way, with uh, tilia and rhodiola and hame and uh, some kids, when they stop being so agitated, they also learn better and show improvement. And parents, of course, are happy to see that. Sometimes this also makes for a more cooperative kit for blood drawn for the blood test. But the first step will be to give these anxiolytic sedative supplements and then on the blood test, if we see inflammation, we also administer some anti-inflammatory supplements such as uridine and sometimes boswellia. And uh,
These are given orally.
everything is systemically, yes. This take the kit takes at home for 1 month or more. And even after administration of cord blood, they're able to sustain the modulation of the immune system because less inflammation is always an advantage. And a less anxious kid, most of the kids have anxiety and agitation. A less anxious kid is also more attentive, more receptive, and can learn easier.
I have to say that from my experience, I see that children who has an anxiety base
Yeah,
before treatment, it's best to balance them with anti-anxiety medication or
yeah,
supplements, whatever the parents feel that reduces their anxiety. Because
yes,
I know one of the side effects, and I've experienced them personally and with some of my patients, are just having some anxiety issues. We
yes,
see hyperactivity, but with children with anxiety base, we also see more anxiety. So I think
yes. After the, it's good that you mentioned this. After the administration of this cord blood of the stem cells, this is the most unpleasant side effect because the uh, pinkish urine, it goes away after the first emission. And there is the smell from DMSO, which also goes away in 24 hours. But some kids, it can be about 1 in 3, 1 in 4 kids, can have agitation after the cells. And this is because the neurons are more stimulated than usual, but it's a global stimulation and it translates into agitation. So these supplements, they can help in this situation. And we had good experience with administering this ansiodep, which will be given here. And I'm sure that in Israel we can find similar preparations.
yeah, definitely.
In
And I will be very, very grateful to you if you can write these issues down and
Sure,
transfer it to us. We will, of course, give
sure.
the group all the information. So parents who are interested to come will have the ability to purchase all these supplements and be ready for it. And once you have finished that part and now the blood unit is being thawed, it's ready to go, how do you receive the blood unit itself?
Um, you mean the day of administration?
Yes.
Uh, After it is thawed and added the albumin and dextrane, it's placed in a regular bag for blood, and then it is administered intravenously by drip, gravitational. It's
Yeah,
not.
gravitational drip.
Yes, and this is done in 20 minutes, around between 15 and 30 minutes. And after this, we flush the tube of cells, and maybe 50 or 100 mLs of saline is given, and that's all the administration. After this, we continue to observe the kid for 2, 3 hours usually, and sometimes we keep the kid overnight if the parents are not from Bucharest. And of course, this will happen in case of parents coming from Israel. They will stay overnight. Uh, some parents who come from out of town, they prefer to go for the night in the hotel because kid, kids hate staying in hospital. It's a foreign environment where they get stuck and painful and fearful, and they will need more sedation and anxiolytics. And so this is essentially the main story, the main course. But around noon, around 12, we give the stem cells via
Drip.
intravenous administration, drip, IV drip, for about 20 to 30 minutes, flush, and then we observe. We remove the catheter in about 15 to 30 minutes, and then we see the child recovering from the analgesia. If they were sleeping, then in 1 hour or two, they sometimes they are a bit groggy. They need to be observed for, way they get out of bed, go to bathroom. They need to be supervised so they don't fall, and these are regular things to take care. So the parent is all the time with the kid during the administration and before that and after that.
So from day of arrival to day of departure, how many days is it?
Um, if we are doing the blood tests, we need 3 days.
3 days.
Uh, if the HLA typing is done in Israel and the blood tests are also done in Israel, then it can only we can only need 2 days, which means arrival the day before, stay overnight, and then arrive at the hospital, administer the cells, stay in the hospital, and the next day you can fly back.
Okay, so for 3 nights, 4 days.
Uh,
Yes,
if
day of arrival, day of testing before, day of
yes,
administration, the night after, and then they can leave. So
yes,
three nights, 4 days. Okay.
this is the long scenario. If we do the testing, all the testing in Bucharest, then we need 3 nights, 4 days. But if HLA testing for the kid and for the cord blood is done in Israel, and NSC and the inflammatory markers are done in Israel, then we only need 2 nights.
Okay.
Night before and night after administration.
Okay. So I am creating now a rehabilitation program for children who do these kind of procedures. I think we discussed it in the past. I am collecting tips from doctors all over the world. In order to, what are your tips for this procedure to be successful with these children post-treatment? So we're looking for post-treatment care.
What I emphasize is address agitation promptly, which means uh, don't let it resolve itself. Give this anxiolytic, this natural sedative like ansiodep. So if there's a agitation issue, treat it. Very important also is to try to keep the kid um, out from possible respiratory infections. Cold, flu is not um, usually it's affecting the immune system. So the whole point is kind of
Keep them
ironically.
healthy.
Yes, try to. I'm saying do the therapy if it's one-on-one, the psychotherapy. After the administration of cells, in 3 days you can start again the psychotherapy. If it's one-on-one or limited exposure, but for a couple of weeks, try to protect the kid from cold and flu. And here we have this spray with propolis and silver, colloidal silver, which is administered in the nasopharynx, which is the portal of entry for all the viruses, respiratory viruses, and try to administer when they go out and when they come back at home. And this way you can protect the portal of entry. Wash the hands and give only thermically treated food, which ensures that the bacteria and viruses are destroyed. So little raw food in these 2 weeks for gastroenteritis and uh, digestive acquired infections. So avoiding for 2 weeks infections and addressing the agitation promptly, I think helps. And also initiating the therapy pretty early, within 3 days after administration, and start exposing the kid to new things. New things meaning new activities, not necessarily new people because you don't want the risk of infection, but try to teach them something new every day. And some of these things will be internalized by the kid and will establish the fundamentals for new notions. And I think it's not wasted time. So even though the kid is not going to school or to kindergarten for these 2 weeks, they can learn new things by uh, uh, the presence of the parents or the therapist, the psychotherapy.
What do you think about hydrotherapy?
Um, it's not a one size fit all. It can help in some cases. I had a patient who was going to Odessa for dolphin therapy, and she was trying a lot of therapies, and they didn't work. And this Odessa dolphin exposure unlocked the kid, starting verbalizing better. Unfortunately, war ensued and couldn't go anymore. There were some kids who started to speak after cerebral lysine injections and intramuscular injections. Some kids did better on sandstone F, which is another supplement for improving focus and memory. Um, most of the kids didn't. Some kids react well to sedivitax, they settled down. Um, so uh, we've seen also opposite effects to the same preparate or medication. So one kid starts crying after tonotil, one kid makes progress after tonotil and gets agitated. But in many cases, a treatment which initially stimulates the kid and makes some progress, after a few weeks, it agitates the kid. The kids get too stimulated or non-specifically stimulated, and it has to be stopped. In these cases, I would first try to add anxiolytic or a sedative to maintain the benefit and eliminate. So I think that supplements are welcome, and very good results were done with the antioxidant optimizer, which is I think from Nature's Way from United States, and it has vitamin D, C, resveratrol, a lot of stuff, and this is very good for kids with genetic modifications also, because it's improving the activity of mitochondria, which is essential for axonal growth and dendritic connections. So supplements have a good role in this, and I recommend to sustain the benefits by using supplements.
Okay, I have
Anastasia,
this question. This is, I think, my last question for today, and I
sure.
ask every single doctor the same question. A lot of my patients ask, when do I know if the treatment has not worked? How long do I need to wait before I can say this treatment was not effective for my child?
I expect improvements in the first 2-3 weeks, and some parents report improvement after 2-3 months. So I think that if we see no progress after about 3 months, then we can see that treatment is not useful.
That's pretty much what everybody else says.
Okay.
So
Nothing.
three, sometimes 4 months at the maximum. If we have not seen any improvement, it did not work.
Yes.
Very sad, but we know that there are children who are not responding for this kind of treatment.
And we're trying to find out why and improve on that.
Yes. Do you think that the child who did not respond to cord blood should try stem cells from a different origin?
Mesenchymal cells are a good option because cord blood has a low percentage of mesenchymal cells. In some cases, 0.1% up to 3%. And giving just the mesenchymal cells may be an advantage, especially for the kids who have some genetic modifications. And you mentioned that in the beginning, and I completely agree with that. So if the cord blood fails, mesenchymal cells are good options, and fortunately there are centers in Slovakia, Poland, I think also in
Yeah.
Belgrade, and in other parts of Europe where they can be administered. We
Yes.
don't do that at this point. We did mesenchymal for stroke, for cerebral palsy, for other things intrathecally, but we have not done yet mesenchymal for ASD. And we're trying to do that in the near future. We're talking with center from Poland, but at this point we're not doing mesenchymal.
Okay. So you are advertising your study soon?
Yes, just put in preprint the first article, which is about the decontamination of two grafts. Cord blood is more frequently contaminated with bacteria, and
20% of the units.
yes,
That's
and
our statistics. I imagine it's the same for you.
this is not an issue for transplantation, and they have not addressed it because transplant patients, they get antibiotic coverage, and it is not very important. But for non-transplant patients, this is an issue because you can't afford to give bacteria by blood. And fortunately, I shown that you can give a concentration of antibiotic, which is 10 times more than the one
Regular.
that kills the bacteria, but does not affect the stem cells because they work on a different ribosomal unit than the human ones. So it's safe, it's effective, and it's not affecting the stem cells. So this is the first article, and we have three
And
more
I
articles.
imagine it will arrive to my email when it's advertised.
It's in preprint, the article, and I'll start working soon on the next two or maybe even three articles, which detail what we found so far, and I summarized to Hagai the findings. This one about NSC and also the different options for genetic versus immune modifications, and we're trying to have an issue, special issue for autistic spectrum disorders by September to summarize all the knowledge that we have and can be helpful to parents because they said kids do not wait for us to discover things, they just grow up and we need to help them in time.
Well, doctor, thank you very much. I'm very excited to read your articles and to help with them to the children of Israel and everywhere else. I will close the record now, and if anybody has a question, they can ask you after. Just a
Thank
second.
you.